Yes, I mean, as more and more patients, especially those with cutaneous malignancies, are now being treated with immuno-oncology drugs like checkpoint inhibitors, the issue of how to manage these immune-related adverse events, which are the primary toxicities of these drugs, becomes paramount. And there are a number of conclusions that I made in my talk that I think are relevant to the practice of medicine for dermato-oncologists around the world. And one is that most of these immune-related adverse events are low grade, but they can be serious and they are rarely fatal. But they are the classic complications that occur with treatment when you're using these immune checkpoint inhibitors. These immune-related adverse events result because you break self-tolerance and you generate autoreactive lymphocytes and autoantibodies, or in some cases, just a very nonspecific autoinflammatory reaction. The most important non-cutaneous immune-related adverse events I talked about were hepatitis, GI, which is primarily colitis, although it includes enteritis, the myocarditis, pneumonitis, and the endocrinopathies. Those would be either the most common in the case of endocrinopathies, GI and hepatic, or the most worrisome, which would be myocarditis, in my view. And again, corticosteroids remain the mainstay or the most basic treatment for these immune-related adverse events. But if you have a severe reaction and the immune-related adverse event is steroid refractory, you really need to move quickly to other immunomodulatory agents. With colitis, for example, that would be Infliximab or remicade, the TNF-blocking antibody. In hepatitis, it would be mycophenolic acid, or other oral agents often used in transplant rejection because infliximab is hepatotoxic. And then it really varies across the board with the other immune-related adverse events, whether you think it's B-cell related, meaning antibodies, or whether you think it's a cellular response. And again, if you don't see relief of symptoms in a significant way by 48 to 72 hours with steroids, you've got to jump on adding other immunomodulatory agents. When patients are treated with steroids, the lesson I learned, my goodness, 21 years ago when I treated my first checkpoint inhibitor patient with ipilimumab, is you don't give a week or 2 weeks of steroids in general for a severe immune-related adverse event. You give at least 30 days of steroids. And if you need to go more than 30 days of steroids, which is the classic with myocarditis, or sometimes hepatitis, you need to have PCP prophylaxis. And again, the problem is some of these immunomodulatory drugs can have organ-specific toxicities that overlap with the kind of toxicities you see with the immune-related adverse events. And again, you have to be a little careful in continuing to use infliximab again and again and again, because you can get, for example, increased risk of infection. And there's always the possibility that you might decrease the benefit of the immune checkpoint inhibitors. So those were really the take-home messages. And I guess the very specific little nuggets of information relate to the fact that with low-grade GI toxicities, often in the US, we use a so-called Medrol dose pack, which is a prepackaged 6-day course of methylprednisolone. With myocarditis, sometimes you need to use pulse steroids. We're talking 500 milligrams to a gram of Solumedrol. That's a very, very high dose, because myocarditis is the one thing that would keep me awake at night when managing these patients. In fact, with most immune-related adverse events, you can even see, say, grade 3 hepatitis that quickly resolves. And in some cases, you can continue treatment if there's rapid resolution after you finish the steroids. With myocarditis, even grade 2 myocarditis, generally in most trials mandates that you stop therapy, that you stop all immunotherapy. So you have to be very careful. And finally, the repertoire of drugs that is useful for managing immune-related adverse events has expanded as people have gotten access to drugs commonly used for transplant rejection or for autoimmune diseases. And it used to just be steroids, infliximab, and mycophenolic acid. Now it includes tocilizumab, which I'll discuss in a minute. It includes IL-12 and IL-23 antibodies like ustekinumab. rituximab, which is the CD20 blocker for B-cell-related toxic effects, or even intravenous immunoglobulin, JAK-STAT inhibitors. There are just a variety of drugs that now can be used, which we've essentially adapted from our rheumatology colleagues.